In this video, we will discuss an exam review on the beta receptors and features of the beta blockers. First, a few important exam questions and then the topic. Question number 1. Why beta blockers decrease mortality in cardiac patients? Number 2. What are the contraindications to beta blockers? Number 3. What's the difference between hydrophilic and lipophilic beta blockers? Number 4. What's the location and function of beta 3 receptors? Number 5. What are the advantages of beta blockers without intrinsic sympathetic activity? And question number 6. What are the first, second, and third generation beta blockers? Now, beta receptors. There are three types of beta receptors: beta 1, beta 2, and beta 3. Beta receptors are activated more by adrenaline than by noradrenaline, whereas alpha receptors are stimulated more by noradrenaline. So the beta receptor are most responsive to isoproterenol. Epinephrine and norepinephrine both are agonists for all adrenergic receptor subtypes. Norepinephrine is synthesized at the nerve terminals, and epinephrine is synthesized in the adrenal medulla and in the brain, but not in the nerves. Norepinephrine is the precursor of adrenaline because the enzyme phenylethanolamine N-methyltransferase is absent in the nerve endings. It's present in the adrenal medulla, and dopamine is the precursor of the noradrenaline. We'll discuss beta 1 and beta 2 receptors separately in other videos, but briefly here beta 3 receptor because it's a smaller topic. So beta 3 receptors are present in the adipose tissues and cause lipolysis. Their stimulation causes weight loss. Synthetic beta 3 reduce obesity by increasing heat production. Where are the receptors located? Receptors are located at the effector cell surface in the extracellular space and combined with G proteins in the plasma membrane. Mechanism of action of the beta receptors. Beta 1, beta 2, and beta 3 receptors stimulate adenylate cyclase and increased cyclic AMP to produce their action. Now, what are the effects of catecholamines on the receptors? Increased catecholamine causes decrease in the number of receptors, downregulation. That leads to decreased response to catecholamines. That's why in pheochromocytoma, where there is increased production of noradrenaline because of increased catecholamine or noradrenaline, there is downregulation of the receptor, so that causes orthostatic hypotension in pheochromocytoma. Number 2, when catecholamines are decreased, the number of receptors are increased. That increases the catecholamine response. So what happens after the chronic use of adrenergic blockers? It causes increased number of receptors, so increased response to catecholamines. So withdrawal of these agents produce hypersensitivity to sympathetic stimuli. Abrupt withdrawal of the beta blockers produces rebound hypertension due to upregulation of the receptors. Why beta blockers decrease mortality in cardiac patients? Number 1, they decrease the size of the infarct and prevent reinfarction. And number 2, due to local anesthetic effect, they have membrane stabilizing effect, especially that of the propranolol. The other beta blockers that have membrane stabilizing effects are the mnemonics is PALM, PALM, P for pindolol, A for Acebutalol, L for labetalol, and M for metoprolol. So these are the beta blockers that have membrane stabilizing effect. The long-acting beta blockers are given once daily dose. The advantage is that they decreases the mortality and they decrease reinfarction in patients after myocardial infarction. Sudden discontinuation of the beta blocker can cause ischemia, so the dose should be tapered over 2 weeks of time. So what's the difference between hydrophilic and lipophilic beta block? The lipophilic beta blockers cross the blood-brain barrier and their toxicity is increased in liver failure. The examples of lipophilic beta blockers are propranolol, metoprolol, and cardiolol. Whereas hydrophilic beta blockers, they don't cross the blood-brain barrier and their toxicity is increased in renal failure. An example of hydrophilic beta blockers are atenolol and nadolol. So lipophilic blockers, they cross blood-brain barrier and toxicity increased in liver failure, whereas hydrophilic blockers, they don't cross blood-brain barrier and the toxicity increased in renal failure. What are first, second, and third generation beta blockers? First generation beta blockers are non-selective beta blockers. They block both beta 1 and beta 2 receptors. Example of first generation blockers are propranolol, timolol, pindolol, and sotalol. So these are non-selective beta block both type of beta receptors. Second generation beta blockers, they are more cardioselective, beta 1 blockers. Examples are atenolol, metoprolol, Acebutalol, and esmolol. We'll discuss them when we come to the beta 1 and beta 2 receptor separate videos. And a third generation beta blocker that are more vasodilator. Example of them are cardiolol and labetalol because they block both alpha and beta receptors. Now, intrinsic sympathetic activity, what is that and how does it work? Some beta blockers cause presynaptic increased norepinephrine release while preventing norepinephrine release from the binding sites of the receptors. So they have some sympathetic activity. So they are both agonist and antagonist due to intrinsic sympathomimetic activity. Examples are mnemonics is CLAP2, CLAP, C for celiprolol, L for labetalol, A for acebutalol, and 2Ps for pindolol and penbutalol. So these are the beta blockers with intrinsic sympathetic activity which increase noradrenaline or norepinephrine release at the presynaptic membrane. These partial agonists or those which have intrinsic sympathetic activity have less effect on the heart and they have more peripheral effects. They cause vasoconstriction. So alpha receptor stimulation leads to vasoconstriction and the vasospastic activity causes coronary spasm, so decreasing the blood supply to the heart, causing angina and myocardial infarction. What are the advantages of beta blockers without intrinsic sympathetic activity? Beta blockers without intrinsic sympathetic activity decrease the rate of sudden death, decrease the overall mortality, and they decrease the recurrent myocardial infarction in patients with CCF, congestive cardiac failure. So these are the beta blockers without intrinsic sympathetic activity. Examples are propranolol, sotalol, and timolols. What are the cardiac conditions in which beta blockers are used? Hypertension, ischemic heart disease, angina, arrhythmia, and idiopathic hypertrophic subaortic stenosis. Now, what are the beta blocker uses in non-cardiac conditions? Hyperthyroidism to control the heart rate, atrial fibrillation, palpitation, anxiety. They are used in anxiety, tremors, and heat intolerance because they cause peripheral vasoconstriction. Now, the side effects of beta blocker: bradycardia, heart failure, left ventricular failure. They may cause hypoglycemia, mask hypoglycemic features, decrease exercise tolerance. They cause cold extremities because they cause vasoconstriction, leaving the alpha effects unopposed, and intermittent claudication. They are also lipolytic, and lipolytic action may increase the triglycerides and decrease high density lipoprotein levels. Now, relative contraindications of beta blockers are severe bradycardia, AV block, severe congestive cardiac failure, asthma, reversible respiratory disorders, mental depression, and Raymond's phenomena is also a contraindication. Now, answers to the questions. Why beta blockers decrease mortality in cardiac patients? We already did this. Number one, decrease in the size of the infarct and prevention of reinfarction. And number two, the membrane stabilizing effect is due to local anesthetic effect, especially that of the propranolol. So decreasing the mortality in cardiac patients. Question number two, contraindications to beta blockers: severe bradycardia, AV block, CCF, asthma, mental depression, and Raynaud's phenomena. Question number three, what's the difference between hydrophilic and lipophilic beta blockers? Briefly here, Lipophilic beta blockers cross the blood-brain barrier and toxicity increased in liver failure. Hydrophilic don't cross blood-brain barrier, toxicity increased in renal failure. Question number 4. What's the location and function of beta-3 receptors? Beta-3 receptors are found in the fatty tissue and their stimulation causes lipolysis. Beta-1 receptor also cause lipolysis. Synthetic beta-3 receptor decrease the obesity by increasing the heat production. Question number 5. What are the advantages of beta blockers without intrinsic sympathetic activity? Beta blockers without intrinsic sympathetic activity decrease the rate of sudden death, decrease overall mortality, and decrease recurrent myocardial infarction in patients with congestive cardiac failure. Examples of the beta blockers without intrinsic sympathetic activity are propranolol, sotalol, and timolol. Question number 6. What are the first, second, and third generation beta blockers? We already did it briefly. First generation non-selective beta 1 and beta 2 blockers. Second generation cardioselective beta blockers, and third generation are alpha beta both blocker vasodilator. Examples cardiolol and labetalol.